My topic that I was given was acute and chronic allograft rejection, and as all of you can imagine, this is quite a broad topic. So what I'm planning to cover today is a portion of the topic that I think is of interest. So rather than focusing on particular management strategies for rejection, what I'd prefer to do is give you an overview of the scope of the problem right now in modern transplantation. And I think that that's an important background to have because it's obviously going to tailor how each of us would react to an episode of rejection and how we should react to an episode of rejection if and when it occurs. So I will go through briefly how you diagnose acute and chronic rejection. And then what I'll spend most of my talk on are 3 questions of interest that I'd like to review the literature for you. And those are, what are the risk factors for acute and chronic rejection? Are Banff scores from liver biopsy predictive of outcomes? And also, how does an episode of acute rejection affect graft and patient survival? Again, with the idea of spending time on the evidence for that because it will tailor how strongly and for how long each of us should react to an episode of rejection when it occurs. So as an introduction, so of course allograft rejection is an immunological reaction to the presence of foreign tissue or organ, which has the potential to result in graft dysfunction or failure. So broadly, looking at deaths and retransplant, we have data now from going back many decades, and we know that the greatest proportion of deaths or retransplant after liver transplant occur within the first year. And most of those are due to infection or intraoperative and perioperative causes. First year, death because of acute infection declines as a cause, and malignancies and cardiovascular disease become much more important. So this is a cohort of patients who were transplanted in the early 1990s. And in this cohort, hepatic causes still accounted for nearly a quarter of the deaths overall in this extended follow-up. However, most of those hepatic deaths were actually due to recurrent disease, not due to rejection. And in fact, only 2% of the deaths overall were felt to be rejection-related. So I think this is important as a starting point of putting in context how often this is actually going to affect outcomes for our patients. As I said. So the incidence of acute rejection in particular is declining. So this is a graph from an early study of patients who were transplanted in 1990s from 3 different centers. And in this study, an episode of rejection occurred in about 65% of that population. This was also from a time period where different immunosuppression was used and also when protocol biopsies were still very commonplace. And this included any severity of acute rejection, as I'll get into a little bit later in my talk. In comparison, if you look at the most recent SRTR data that we have available, now what's being reported back to SRTR is an acute rejection rate within the first year of less than 15%, and in fact it continues to decline, as you can see from the bar graph. So today, death or retransplant due to acute or chronic allograft rejection is very uncommon throughout the first 10 years after transplant. And in fact, the most recent SRTR data, which is from 2014 transplants, shows a 6-month graft failure rate of only 7.8% and a 1-year rate of 10.3%. So overall, what is this telling us? So certainly the liver is more tolerant for immune-mediated injury than other solid organs. And in general, we all know that the requirement for immunosuppression does decrease after the first year post-transplant. Currently, looking at what's being done in the most recent sort of decade of reported data, calcineurin inhibitors, in particular Tacrolimus, still remain the backbone of immunosuppression. But even from this data, you can see that actually use of steroids is decreasing, and there's more reliance on MMF. So some of these trends, what I wanted to point out is that there's other changes that have been happening in recent years as well. So in particular, why do we still see a decrease in acute rejection compared to historic cohorts? The answer to that question likely is for a few different reasons. It's possible that part of that is due to use of induction agents at the time of transplant, which has been increasing in prevalence at different programs. But there's other possibilities as well, and one of them I mentioned that In the past, there was a lot of reliance on protocol biopsies, meaning that everybody got biopsied at certain points post-transplant, regardless of what their liver test looked like. And so now with that being done by less and less programs, probably we're not detecting as much milder acute rejection that used to be reported back to SRTR.
Do you know if that has to be biopsy-proven rejection? Or it's,
no.
So it can be reported?
Yeah, it's reported. It can be clinically suspected. So why do I give this historical background? Well, we all know that there are a myriad of consequences to immunosuppression. And that's true both for patients' maintenance immunosuppression and also true of what we give them when we respond to an episode of rejection in terms of upscaling their immunosuppression. And as I showed you in the first slide, when we see that the main causes of death, especially in extended transplant follow-up, are actually not due to rejection and retransplantation, but rather due to things like cardiovascular disease and malignancies, I think we all need to put that in context of really understanding how much and for how long we should be increasing patients' immunosuppression when they have rejection. So now I'll take a step back and go through more of the basics. So how do we actually diagnose acute and chronic rejection, and what is that? So the terminology of acute and chronic rejection, for those of you that are not transplant hepatologists, is misleading because really they're not defined based on the timing. It's true that acute rejection occurs most often in the first 6 weeks after liver transplant, and can be more common in the first year of transplant than later than that. But it really can occur any time post-transplant, even months or years later. And chronic rejection really can occur at any time, even several weeks after transplant. There's what's called early chronic rejection. The mechanisms of injury for acute rejection, it's really a complex interaction between recipient T cells and donor and recipient antigen presenting cells, which lead to activation of TNF-alpha superfamily receptors and causes a myriad of changes. And so that's a more cellular mechanism for acute rejection. Chronic rejection, the understanding of that is still very much evolving. So I think in the past the focus was still on cellular mechanisms for chronic rejection, and now I think there's a growing understanding that actually humoral-mediated antibody-mediated immune reactivity may also be very important in chronic. Now, in terms of the pattern of liver test abnormalities, acute rejection can have elevations in alkaline phosphatase, GGT, AST, and ALT. When it's severe, you also see jaundice, as well as you can have a rising INR. Chronic rejection tends to have more of a cholestatic pattern, but the truth is there's variants of both, and so there can be substantial overlap in the pattern of liver test injury between acute and chronic rejection. So because you can't rely that much on the pattern of liver test injury, nor can you really rely on just the timing post-transplant, ultimately we really need biopsy to definitively make a diagnosis of either acute or chronic rejection. So histologically, how are these diagnoses defined? So the three main features of acute rejection are portal inflammation, bile duct inflammation and damage, and venous endothelial inflammation. So what I have here on the slides are an episode of very classic acute rejection. What you can see on the left here is a lot of eosinophils, portal inflammation that's mixed with lots of eosinophils. You can see white blood cells approaching the endothelium, causing an endotheliitis. And then here on the right-hand side, you see a bile duct that, although it still has sort of that classic pearl appearance to it, clearly there's already some degenerative changes. You can see irregular appearing nuclei and so on. So if you go and see it, so I wanted to also show you some more severe examples of these injuries. So the top photos here are showing now very severe bile duct inflammation and damage, where unlike the picture on the previous slide, these bile ducts are almost unrecognizable by a non-pathologist like myself because of how inflamed and damaged they are. And on the bottom slide here, you can see that there's such severe endotheliitis that you're actually, in addition to seeing all this invasion of the vein, you have dropout of hepatocytes near the central vein as well. Sorry, near the, yeah. So in contrast to those images, how do we diagnose chronic rejection? So chronic rejection really has two classic features. The first is bile duct degenerative changes in early chronic rejection that later leads to bile duct loss in late chronic rejection. And then foam cell obliterative arteriopathy. So on the left-hand side here, this is an image of early chronic rejection, where you see a very abnormal appearing bile duct. It's very pink appearing. It clearly doesn't have normal looking nuclei of the cells. And here on the right-hand side, you have a complete bile duct loss. So this is now an example of late chronic rejection. And on this slide, I wanted to show examples of the foam cell obliterative arteriopathy. So here you can see an arteriole that's basically filled with foamy cells. And the foam cells actually can also be found scattered throughout the liver parenchyma. So again, going back to the need for biopsy, there is significant data, which I'm not going to go through in detail, which tells us that abnormal liver tests in a post-transplant patient are neither sensitive nor specific for a diagnosis of either acute or chronic rejection. And as all of you are aware, there's a broad differential diagnosis in these patients, including recurrent hepatic disease, biliary damage, vascular issues, as well as other infectious causes, only some of which can be ruled out through other means such as imaging. So there is really an important reliance on pathology for making these diagnoses. And that's true of when you look at guidelines that, for how we should be approaching abnormal liver tests in patients, whether it's in the early transplant period within the first 6 months or after 6 months. Basically, unless you find something obvious on imaging that needs intervention, a lot of times biopsy is going to be the next step. So how do we classify acute rejection? So there are differences between early and late acute rejection, and I'll go into some of the outcomes with those. You can classify it based on whether it's purely histologic, meaning with normal liver tests. That's back from, again, historically when there were more protocol biopsies being done for patients at certain time periods post-transplant, and still being done by some programs that are trying to do withdrawal of immunosuppression in patients. So they'll use protocol biopsies prior to withdrawing immunosuppression, or clinically relevant rejection where you see both the pathology that's classic for rejection, but on top of that have abnormal liver tests that fit with that. You can classify it based on histologic severity, which I'll discuss in more detail, and then whether it's steroid responsive or steroid resistant.
So before you go further, I'm happy that you used our Mount Sinai expert guides in terms of the algorithm for assessing rejection, but we do spend a lot of time looking at labs, especially early on in the first 6 months of transplant here, and looking for subtle biochemical signs that suggest there's a problem with the allograft. And so, despite the fact that it's non-specific, we rule out kind of major causes structurally, depending on the patient, of course. We're looking for some subtle sort of changes in the liver tests, and a lot of that is kind of like the art of immunosuppression, right? So, maybe an asking of some of the more experienced hepatologists, Tom, what are the things that you're looking for in the profile that gives you a subtle clue of rejection, if other things are pretty straightforward? Pattern.
It's become a lot easier since Orth, you don't have to worry about hepatitis C, right? So then when the liver test would go up, it's a recurrent hepatitis C, everyone had a high viral load, so it really made it a lot more complex. Without hepatitis C present, any mild elevation in the liver test, we tweak the immunosuppression, and if optimizing your prograft level, for instance, doesn't make the liver test improve, then I would get an imaging study. You just diagnose two people with CMV because of the appropriate time after the transplant. That works into your differential. I'm always much more worried when the bilirubin goes up. And if your bilirubin is not elevated, I think you have some time to sort of think about what's going on and make some change. Once the bilirubin starts going up, I'm a little more concerned.
I think my impression, and again, I just didn't have the time to spend too much on management strategies, but I think that, as you said, when you're tweaking the maintenance immunosuppression, you may not need to rely on biopsy, but I think if there's consideration for putting somebody on high-dose steroids because of suspicion for acute rejection, I think that's where you really want to maybe first be certain that you're really making the correct diagnosis.
So is it more of a cholestatic pattern that you're concerned about? Because the alpha sometimes never really comes down. Priya, what do you think? What do you look at? Transaminases more? Alpha, GGT, all of it?
Whenever you have everything going up, it's usually rejection. So for me, nothing is really specific. But if it's across the board, I always suspect rejection. So the GGT goes up, the alpha goes up, everything goes up. To me, that is. But I think the history is crucial. A lot of times, if you know the patient and had some event, for example, a diarrhea or something, their program is lower or their cells are blocked off, usually the history is very telling.
So, and I'll talk about in terms of medication adherence issues and so on. I'll talk a little bit about that. So briefly, when you get back a pathology report for a post-transplant patient that has rejection, that has acute rejection, the pathologist will nowadays use what's called the Banff Rejection Activity Index. So there's really two components to this. So this is based on expert consensus for how acute and chronic rejection really should be described by pathologists, so that it's done in a uniform way that hopefully will help guide management and guide prognosis. So for acute rejection, again, the three features you're looking at are portal inflammation. So is it involving most of the portal tracts? Is it expanding those portal tracts? And is it spilling over into the parenchyma? For bile duct inflammation and damage, is it involving some or all of the bile ducts? And how degenerated are those bile ducts as a result of that inflammation? And then for venous subendothelial inflammation, again, is it involving a minority of the venules or all of them? And then do you see that severe hepatocyte dropout like in that image that I showed you? That would put it as a score of 3. And so these scores, when you sum them together, they do correlate with another part of the Banff consensus guidance, which is really just the pathologist's subjective global assessment of the severity of the rejection episode. So this is sort of overall how the scores correlate with that global assessment, but these things are sort of done somewhat independently as well. One caveat I wanted to point out is that really I'm giving you a little bit of the simplified version of this, but there's of course subtleties to this. Pathology itself is an amazing art. And for example, late acute rejection in particular can really have some variance to it. One of them is isolated central perivenulitis, which really doesn't have the other classic features of acute rejection. And this is one way that late rejection can manifest. And so there was an updated Banff guideline that was published that basically said that there's actually different descriptors that pathologists should use for that variant. For chronic rejection, there's also guidance for how it should be described, and that really is focused on differentiating between what's considered early chronic rejection and late chronic rejection. And so again, as I mentioned before, early chronic rejection, you do see degenerative changes of the bile ducts, but there's loss in less than 50% of the portal tracts. And in contrast to that, in late chronic rejection, you see loss of bile ducts in more than half of the bile ducts, and you see degeneration of the other ducts as well. And I think that the reason that all of these subtle pathology changes are important in whether it's early chronic rejection or late chronic rejection is that, again, this can impact management strategies. So for early chronic rejection, a lot of times it's going to be increasing their prograph, increasing their immunosuppression. For late chronic rejection, especially if it's accompanied by deep jaundice, I think more you have to start thinking about whether retransplantation is an option. So now where I'd like to really spend more of my time is addressing some of these questions and going into the literature in more detail. So in particular, what are the risk factors for acute and chronic rejection? So one of the earliest studies to look at this was a study that used the LTD cohort, which is from 3 different centers. And this was patients who were transplanted in the early 1990s. So they were immunosuppressed for the most part with azathioprine and cyclosporine. And There's a number of different risk factors that they found to be associated with the risk of early acute rejection, which in this study was defined as within 42 days. Now I think we usually sort of think of it more in terms of a 3-month cutoff, but that's quite variable between studies as well. What I'd like to point out is that really of all of these, age, donor age, and cold ischemic time are the ones that you're going to see again and again in studies that I bring up. A lot of the other things that are found on this initial study, there's really mixed results between studies. And I think that's important because, truthfully, we're all still trying to understand, especially as immunosuppression management has changed, what the risks are in the more modern transplant population. So this is now looking at risk factors for late acute rejection, and this is a study from Baylor University in Dallas, looking at patients who were transplanted in 1985 to 2003 who survived at least 2 years. What I wanted to point out here in this study is something that I think clinically we all know, which is that the risk of rejection does vary by your initial diagnosis for why somebody underwent transplant. And autoimmune hepatitis and primary biliary cirrhosis and PSC really carry a higher risk of late acute rejection. I'd like to point out on this slide hepatitis C, which sort of is lowish in terms of risk of rejection, at least in this study, but I'll contrast that to some future studies that I'll present to you in a moment. Aside from diagnosis at the time of transplant, female recipients and younger recipients also appear to be at increased risk. And that's something that is, again, maybe correlated with the etiology of why they required transplant.
I think it's interesting that from a non-immunologic perspective, those patients who are likely to not be very adherent to medicines, perhaps, as a cause of their late rejection. You would think alcohol and Hep C might be really high on the list, but they're actually the lowest.
They're very immune tolerant. Yeah. So this is a study from Birmingham in the UK. It's a more recent cohort in the 2000s. And again, showing very high risk of late rejection in patients with PBC and PSC. Interestingly, the risk for autoimmune patients in this cohort seemed to be a little bit lower. I don't know what the explanation for that is. And again, very, a much lower risk in the hepatitis C patients. And this is for biopsy proven. In their multivariate analysis, the 3 biggest risk factors for late acute rejection were PBC, younger recipient age, and if this was a regraft. The choice of immunosuppression clearly matters when it comes to the risk of acute rejection. And this is one of the few areas in this field where there's really not just retrospective and prospective cohort data, but really randomized clinical trials to help guide us. So I'm presenting here data from 2 large and important randomized trials that were done comparing immunosuppression post-transplant with Tacrolimus and cyclosporine. The image on the left is from a study that was done in the US, published in the New England Journal of Medicine, and on the right-hand side, a European cohort published at the same time. And in both studies, you can see that the risk of acute rejection was higher for patients who were randomized to the cyclosporine group than for the patients who were immunosuppressed with Prograf. That being said, both of these studies were actually powered to look at differences in graft survival, and there weren't differences in graft survival in these clinical trials. So something else to keep in mind is that certainly if there's other reasons pressing you to change your immunosuppression for patients from Tacrolimus, which is sort of standard, at least at this program, they may have more rejection, but it may not necessarily impact their long-term outcomes.
Were you surprised to see an ACR rate of 60% even in the best group?
Well, this is also earlier on. So this is also before the, a lot of the induction therapies and so on. So I think back in the early 1990s, that fit with what I've seen in previous studies as well, in the cohort studies.
These are all protocol biases too, right?
Correct. Correct. Yeah.
In these older studies, do they talk about trough levels or concentrations of these drugs?
I believe so, but to be honest, I don't remember what the details of that were for either there is another clinical trial that looked at actually switching patients from Tacrolimus to sirolimus, and this was driven by the fact that for some patients it may be helpful to do that in order to protect the renal function. And similar to the previous two studies that I showed you, the patients who were switched to sirolimus, which is in the dark line, did have increased rates of rejection. But again, like in the previous studies, this didn't actually translate to worse outcomes in terms of graft or patient survival, which to look at. So this is a study actually coming from RMTI here at Mount Sinai with some familiar authors. And so this is actually looking at the question of adherence, and is there a way that we can be more suspicious of rejection, like you were saying, in certain patients? So this was a retrospective study looking at 150 randomly selected adults who were all on tacrolimus for immunosuppression in the years 2007 to 2010, and who had at least a few spaced out measurements of tacrolimus levels. And what the authors here did is they looked at the standard deviation for a particular patient within those tacrolimus levels over the years of this study. And that standard deviation is what they're calling the medication level variability index, or MLVI. And this is something that's been actually studied before this paper in the pediatric population quite a bit as something that indicates poor adherence and also increases risk of rejection. But this is one of the first studies to look at it in the adult population as well. And what you can see is that patients who had rejection did have more fluctuance in their tacrolimus levels compared to the rest of the cohort, to patients who on biopsy had a different diagnosis aside from rejection. And that the higher that fluctuance was, the more your proportion of rejection. So blue here represents rejection and red meaning no rejection for patients. So I thought that this was interesting because clinically, especially if you're in a situation where you may just want to optimize immunosuppression and not necessarily jump to biopsy, this is actually a tool that we can easily use in practice to, again, suggest that maybe this is somebody who has not been that adherent with medication and who we really think is at higher risk of rejection, and maybe we should just go ahead and tweak their immunosuppression. So what about living donor transplant? Does that affect risk of rejection? So there's data from the A2L cohort where they looked at patients who had been, they had a donor that was evaluated, and then some patients in that cohort underwent living donor transplantation, and some of them underwent deceased donor transplantation. And actually, when you restricted the analysis to biopsy-proven rejection episodes rather than just anything that was clinically suspected, there really was not a big difference, at least in this study, between deceased donor and living donor transplant. And in both segments of the cohort, the patients were clearly sensitive to cold ischemia time in terms of their risk of rejection. And this confirms what I showed you in that earlier study from the LTD cohort in the 90s that also found longer cold ischemia time to be a risk factor for acute rejection. So more recently, there's been data now presented in the past year that looked at a more recent decade of A2L cohort patients and also looked at SRTR data from similar years. And this is in contrast to the last slide. So here they actually found that biologically related patients that received living donor liver transplants versus patients who received a non-biologically related living donor or a deceased donor liver actually had a much lower risk of rejection. That was true both in the A2L cohort and also in the SRTR data overall. And there were some other kind of interesting and difficult to explain findings in this study. So, for example, in the A2L cohort, Asian race appeared to be a risk factor for acute rejection. In contrast, it appeared to be protective in the SRTR data. And that's something that I don't think there's a clear explanation for. And then hepatitis C actually appeared to increase risk of acute rejection in both parts of this study, and that's in contrast to some of the earlier cohort studies that I showed you, where in contrast to autoimmune hepatitis or PBC, the risk of rejection seemed to be lower in hepatitis C patients. So the reason I wanted to point out some of these differences is that I think this is very much still an active area of research where we're still trying to build our understanding, and A lot of these differences may be because, again, this is a more recent cohort that's being immunosuppressed and managed after transplant quite differently than the patients that were being initially seen or even seen in the early 1990s. So similarly, just raising more questions, there's been a question of, is cross-match important in liver transplant? And the feeling is that certainly not as much as in kidney transplantation, but there's this cohort out of Japan that looked at living donor liver transplant recipients and found that patients who had HLA-DR mismatch and also patients who had a positive T lymphocytotoxic cross-match study were at significantly higher risk of acute rejection in this cohort. So again, I think there are still a lot of open questions in this area. For chronic rejection, for the sake of time, I'm summarizing here data from a number of different studies. So as you might expect, having episodes of acute rejection and particularly severe or steroid refractory episodes increases risk of developing chronic rejection and graft failure. Being transplanted for PBC and autoimmune hepatitis also increases the risk. Young recipient age or old donor age also do. And the bottom two here, so whether there's an issue of sex mismatch increasing risk of chronic rejection, that's something that really was reported in one study back in the cyclosporine immunosuppression era. It hasn't really been verified in other studies that have looked at that as a risk factor. So I don't know whether that's truly a risk factor, but it at least is reported in that one study. And then more recently, there's a question of whether transplanting somebody, a CMV IgG positive donor into a CMV IgG negative recipient may also increase risk of graft failure. So now moving on to the next question. So the biopsy scores, are they useful to help predict outcomes? So I wanted to bring up data from two studies here. This one is from a study in University of Pittsburgh Medical Center of 901 patients who underwent deceased donor liver transplant who were immunosuppressed with tacrolimus and steroids. And as you can see, although acute rejection was quite common in this population in this era, moderate or severe acute rejection was less common. Acute rejection was in general found on a minority of the biopsies. In fact, recurrent disease was much more common. But getting to the question at hand, so in this study they looked at both the total RAI scores and also the component scores for portal inflammation, bile duct inflammation and degeneration, and endothelial inflammation. And the scores did correlate overall with pathologists' global severity, so that part has been really validated in a number of studies already. But the component scores for bile duct damage and endothelial inflammation were the ones that correlated best with alkaline phosphatase and bilirubin levels, portal inflammation less so. Patients who had more portal inflammation and more endotheliitis tended to have more fibrosis on follow-up biopsy. And the endotheliitis, for whatever reason, seemed to be most predictive of long-term risk of graft failure due to acute or chronic rejection, at least in this initial study. So another study that looked at this more recently was a retrospective study of almost 500 patients in the UK. This is a little bit of a more modern cohort. And in these patients, it was really the bile duct inflammation score that seemed to be most predictive of harder to treat acute rejection. So in this particular case, the need for further bolus treatment with corticosteroids after an initial bolus. But on the other hand, and this is where I want to bring up the fact that, again, there's just a lot of open questions still here. The score for endotheliitis actually was inversely associated with liver death in this cohort. And the authors were actually quite thorough in trying to look for things that may have confounded this association, because it was certainly an unexpected finding in their study, and really were not able to account for it with any clear confounders, such as prevalence of hepatitis C in patients with different levels of endotheliitis and so on. And really, none of the RAI subscores or the total score were predictive of graft failure or chronic ductopenic rejection. So the reason I wanted to point out these two studies is that I think, quite honestly, my findings were that it's really a good pathologist's subjective assessment of the severity of rejection that is much more validated and reliable, I think, in guiding management and in being associated with outcomes, rather than these sort of numeric scores that I think were developed more with research interests in mind, and I think still need to be validated in further studies moving forward. So lastly, I'd like to spend time on this important issue of how does acute rejection affect longer-term graft and patient survival. And this goes back to the question I started my talk with, which is, how much should we react? How much should we be worried when this happens? So first of all, just briefly, and this goes back again to the era of protocol biopsies. So this is a study looking, it's a pooled analysis, in fact, of 15 studies, but they're all relatively early studies, mainly in the cyclosporine era. And this is for patients who all received a protocol biopsy within the first 3 weeks after liver transplant. And in that cohort, a number of the patients had histologic acute rejection, but didn't have any biochemical graft dysfunction. And so this is an important study just to realize that for the patients who had histologic acute rejection but didn't have any biochemical abnormalities, the vast majority of them in follow-up didn't have any subsequent graft dysfunction, despite not having their immunosuppression changed. And in fact, in that population, rejection rate was 4%, which for especially the time when this study was conducted was quite low. It was at least 10 to 15% in most of the published literature in this era. So this is just to point out that, you know, if for some reason you have a protocol biopsy on somebody that shows rejection but their graft function looks good by their liver tests, there's really probably no reason to jump to adjusting their immunosuppression until you start to see biochemical graft dysfunction. So that's sort of a issue that I think is not as important in modern times. What's more important is what's happening with patients who have acute rejection that's biopsy proven and that is causing biochemical graft dysfunction. So there is some data that suggests that survival after early acute rejection may actually be better. So this is a study from that LTD cohort from 3 centers, again, transplanted in the early 1990s. And in the Kaplan-Meier analyses, the survival for patients who had an episode, or at least one episode of acute rejection, actually appeared to be significantly better than for patients who didn't have any rejection. That being said, this lost significance after adjustment for other survival risk factors, such as recipient age and so on.
Is that an phenomenon, or why might that be a true finding?
So your question's well taken. So I mean, it could be sometimes just that when you adjust for risk factors, of course, you decrease your power in the study. But I think that part of the reason I wanted to point that out is that, as I'll show in some of the more recent studies, it's not clear that actually there is a protective effect of having early rejection. So I think that it could be that, in fact, this is just a result that is, in fact, confounded by those other factors associated with survival, and was being biased away, you know, away from the null.
Many years ago, one of the surgeons' comment was, liver transplant surgeons, was, you know, a little rejection is a good thing, because in a way then you know that you're not over-immunosuppressing your patient. We don't have a way of assessing over-immunosuppression where people die of infection and other issues. So, you know, maybe there's something to that, at least with mild degrees of rejection.
And that's absolutely getting to the point of why this whole question was of interest to me, is because I think that I worry very much that it's easy to over-immunosuppress patients. Their labs look good, you know, everything seems to be going smoothly, but we're probably increasing their risk of a lot of different things. So your point is very well taken. So I'd like to show you data from a few more recent studies as well. So I like the title on this one, No Effect on Late Hepatic Allograft Function in Man. It's very dramatic. So actually what these authors did is they just were looking at prospectively what the liver tests were at one time point, about 1 year after liver transplant, and comparing that for a small group of patients who had an episode of acute rejection and a group of patients who hadn't. And really they didn't see any significant differences between those groups except for serum bile acids. So for what that's worth. Now, in terms of late rejection, this is where there's stronger data and fairly consistent data. So this is a study coming from Baylor University, again in Dallas. I showed you some of the risk factor data from this study earlier. And here you can see in the survival curves that for patients who had an episode of late acute rejection, which is the solid line, their survival was worse. And this remains significant even after adjustment for other survival risk factors. I'm showing you here the graph that's for patient survival, but differences were also there when you looked at graft survival alone. This is another excellent study coming from Birmingham in the UK. And here they actually looked at 3 different categories: patients who had an episode of early rejection, patients who didn't have any rejection, and patients who had late rejection. And here they divided it by that 90-day threshold that I think we more commonly think of. And this is one strong study that did seem to show that patients with early rejection seemed to fare better than patients who either had no rejection or patients who had late rejection. So going back to your point that maybe a little early rejection is a good thing. I don't really know that we can say that a little late rejection is a good thing. And again, there is conflicting data even in this field. So this is data from that more recent study from the 2017 publication that used A2-all cohort and SRTR data. And what I'd like to point out here, regardless of whether you're looking at the A2-all or the SRTR halves of the data, is that the solid line, which is patients who had no rejection, were the ones who fared best, who had lowest risk of mortality and lowest risk of graft failure. So this is another example of a cohort where early rejection within the first 6 months or the first year was not associated, at least, with improved survival.
Do you have an understanding of the causes of death for any of these studies?
So I'll tell you, in this study, it was really all causes combined. And so in this one, this is actually looking at graft survival, which I think is really the endpoint that we're most interested in. But here, again, the bottom half, you're looking at graft failure. Now you're mixing into that, of course, recurrent hepatic disease sometimes. So, and so much of that is hepatitis C driven, I think, for a lot of these patients. So it will be very interesting, I think, moving forward now in the era of treating hepatitis C to see whether some of these trends are affected by that.
Graft failure is a very broad term.
Yeah.
Define graft failure in any way? What are they looking for exactly?
That's an excellent question. You know, I don't recall in this study how it was defined. Yeah. It was not, there are earlier studies where it was really like need for retransplantation or so on, but I don't recall for this one. So just to summarize, so acute and chronic rejection are less common than they were historically, but they're still a concern, and that's especially true in patients where there's a reliance on maybe atypical immunosuppression, or there's concerns for non-adherence, and it certainly is a concern if attempting withdrawal of immunosuppression in patients. Fluctuating drug levels may suggest non-adherence and can be a sign that a patient is at increased risk for rejection. But in most patients, in many situations at least, confirmation of rejection requires biopsy. And that can also help guide some treatment decisions, looking at the severity of the different components of rejection, as I've shown you. And late acute rejection does appear to increase your risk of chronic rejection and graft failure, but I think the jury is still out for whether early acute rejection adversely or positively affects outcomes. Thank you.
Great. Very nice synopsis. Thank you.
Question?
That was great, Nitzan. It just occurred to me, one of the things that's happening in cancer pathology is machine learning approaches to integrate information in an automated way to define particularly prostate cancer and then breast cancer. I wonder if it's something we should think, you don't need to answer this, but I wonder if there's something we should think about in non-malignant disease, particularly liver, because there are so many elements that are semi-quantified, and it seems to me it's critical information. And if you don't have a particularly experienced pathologist, as we're fortunate to do, you may get into trouble.
Absolutely. I think that that's an area where I think it it's nice to see, as I was delving into the literature, that a large number of programs appear to be prospectively collecting very detailed data that could aid an effort like that. And of course, now as we have more electronic medical records, I think hopefully we can do more big data approaches to studying some of these questions.
Right. I mean, I think for sure in radiology this will happen in your career, probably not in mine, but where most routine exams are just evaluated, you know, through a computer automated and then probably certified by a radiologist.
So Nitzan, in your examination of this topic, when do you think a biopsy that should be done? It's really important in diagnosing acute and chronic rejection. What do you think sort of the scenario is where it really is optimal?
So I think that for acute rejection, I think that if the feeling is that this is mild kind of rejection where you're just starting to see the numbers go up, and it may be something that can be solved by just optimizing maintenance immunosuppression, I don't necessarily think you always need a biopsy. But I think considered before putting somebody on high-dose steroids, especially because putting them on high-dose steroids obviously carries with it so much risk that you want to be sure of your diagnosis. And that's especially true if you don't have something like the medication variability and non-adherence that's clearly pointing you towards a higher risk of rejection in that patient. I think that it's also important to consider biopsy and acute rejection if you initially put somebody on steroids empirically and they're failing to respond to that before continuing to escalate that indefinitely. For the question of chronic rejection, I think it's something that is probably very important when you're trying to make a decision about whether to, especially in a jaundiced patient, whether to really increase their Tacrolimus immunosuppression substantially, like you need to sometimes to reverse early chronic rejection, or to try to get a sense of, is it too late for that, and is this somebody who's heading towards retransplantation? And I think that sometimes, obviously sometimes you can look at the lab and feel like the situation is too late, but sometimes the biopsy, I think, can be very helpful in that regard, because certainly if you see very, very high percentage of bile duct loss, I think that may, shift the decision making in one direction or the other.
Yeah, that reminds me of a really important teaching point that sometimes happens where you might want to seek out doing liver biopsies very close to each other, which you don't normally do serially, and that sort of jaundice chronic rejection scenario is one of those key features. Tom, I don't know if you want to comment. I learned that from you, so.
Yeah, no, I think that we like to do biopsies. I mean, we should, when we're managing these patients, I think repeating biopsies to look for effect of the therapy, I think is exceedingly important. Also because when you're giving someone a lot of immunosuppression, you are at risk for them having CMV and non-hepatic viral infections, PTLD, and other things. So I actually like to repeat a biopsy when people are in the hospital for 7 to 10 days, for instance, just to see how they're doing. And you have to change your immunosuppression. You have to rebolus them. Are you going down the road of giving them more Tacrolimus? Because obviously there are risks with all of these medicines. We give bolus Medrol all of the time. I've seen a couple of cases of bad pancreatitis related to that, which could be problematic in these people who have sick livers. So I think repeating the biopsies is a very good idea. And I think you have to be patient when you manage these individuals, because we want to get people out of the hospital very, very quickly sometimes. And I think that if their progress levels aren't stable, if they really don't understand their medications, you risk them going out and making a mistake, and then the horse is out of the barn, and then you have to retransplant.
One of the things that struck me as I was reviewing the literature that's really along those lines is that in one of the earlier A2All studies, they actually saw really substantial variability between different centers in terms of rates of rejection. And I think that again speaks to not just differences in initial immunosuppression, but probably also different approaches in how people are reacting to abnormal liver tests. And some places are better than others at it, apparently.
Why it's so difficult to do randomized controlled trials in a post-liver transplant setting because of this variability. It's interesting also that it seems that there are more patients who have chronic rejection and chronic allograft failure that are now coming to retransplantation. And we're seeing this in our program. Very often, a lot of them are coming from other centers that have turned them down for one reason or another. And this may be because, you know, as we're retransplanting less people for recurrent hepatitis C, we're sort of opening the doors to these other diagnoses to try to transplant such patients. So we may actually be transplanting more of these people who have allograft failure from rejection than we did, say, 5, 10 years ago.
So at least the burden maybe of hepatic causes of retransplantation or death may be shifting back from recurrent disease to rejection related.
And I don't know if you mentioned this explicitly. Has anyone actually assessed histologic sampling variability? Now, you're talking about variability in drugs, but you know, for things like NASH, it can be for fibrosis staging, it can be up to 50%. Has anyone or compared it to biopsy, for example?
For rejection, I don't know how that you could necessarily use explant,
Unless
but
it's transplant, obviously.
But I think that there's been some paired biopsy studies, certainly, and the issue is that they're not done at exactly the same point in time, and there's typically been at least some tweaking of the immunosuppression. So one of the studies I showed that looked at sequential RAI component scores was looking at paired biopsies, and they certainly saw differences between the paired biopsies, but it's unclear how much of that was due to, you know, heterogeneity within the liver and sampling issues, and how much was due to just the effects of whatever changes were made to the immunosuppression. So it's, I think, it's hard to do those studies in contrast to maybe in NASH, where there's fewer dynamic changes being done with the medication.
Yeah, you know, the other approach, which I think isn't used routinely in this disease, but in cancer it is, which is to do transcriptomics. So in other words, instead of relying solely on what the pathologist tells you, is assess, you know, the universe of gene expression in the tissue. That's such a deeper data set. It's going to be really useful to see if there is a signature that emerges from that kind of a global assessment.
So there's actually a number of different potential biomarkers that are being studied as early markers of rejection. So there's some, for example, like microRNAs that may end up becoming, you know, viable biomarkers for rejection, and may actually be elevated even before you start to see biochemical graft dysfunction. So I think that's very much an active area of research.
Yeah, I keep saying it, but we've, for better or worse, been wedded to biopsy and the origins of our specialty, and that's been a useful thing, but it's also a little bit constraining.
Yeah, there's actually, you know, just to finish up the thought about personalized or precision medicine and transplant, there was some recent data looking at the kidney transplant patients, looking at SNPs, you know, gene expression to predict those who require higher doses of.
Right, actually, I should have mentioned that. So Barbara Murphy is an international leader and has defined exactly that kind of signature for renal rejection. Maybe that's why I thought of it.
Yeah, so maybe you could preemptively put them on higher doses because you know they're going to not respond as well. All right, Nitzan, this is fantastic. Great work.